Hello? No, do you hear us here? Yeah, good morning.
Good morning. Good morning.
Yeah. How was the Great Hall? A lot of audience? A lot of audience or?
You are caring about how many audience there. It's enough to have chairpersons, no problem.
The chairperson are very heavy people, yeah. 200 people, yeah.
Okay.
Fine. First of all, I would like to represent Professor Imad Shiban from Italy. He's our honored guest today. I will work with him in the case. We have to welcome the crew here in the Alexandria University Hospital, the main hospital. We have here the cooperators, Dr. Saeed Abdelati and Dr. Ahmed Yahya. We have the residents, Dr. Ahmed, Dr. Muhammad, and also we have the nurse, Madame Mona, and we have the tech nurse, Mr. Farouk, and we have the IVIS man, Mr. Amr Kamal, and also the head nurse here is Madame Abir and Madame Hind are the head nurses of the hall here, and myself is Amr Kamal. I am today will give the opportunity to Dr. Saeed Abdelati will present the case of today, which is a case of instant stenosis. And we expect a very tough and very hot discussion and interactive discussion with you. So Dr. Saeed could present the case.
Just before, I would like to thank again the organization gave me this opportunity to come back to this, to work with this fantastic team of my friends here. And I think today we do not have a difficult, technically, it is easy thing to do, but conceptually I think there is too much to discuss. And I think this is very educational case. So please, go ahead and presentation.
Our case today is a 59 years old male patient, ex-smoker, diabetic and hypertensive. The patient have an acute coronary syndrome, inferior STEMI on 2008, PCI with RCA and posterolateral branch 2008, and the patient complaining now of chronic stable angina, cardiac class 3. The patient have an echo about 54% ejection fraction and posterior and inferior wall hypokinesia. The patient syntax score here is 0.2. And Euro score is 8, and Euro score 2 is 18.6, and Euro score 2 is 0.65%. This is the standstill images of the coronary angio, previous coronary angio, and Dr. Amr will present the data on this coronary angiography.
Yeah, thanks, Dr. Saeed. Actually, the patient was, he's diabetic patient, and he underwent PCI with a bare metal stent in 2008 for the mid-RCA. Then few months later, he presented with recurrent angina, and there was an instant stenosis within the bare metal stent. It was a Zeta stent 3/38. Then focal instant stenosis was found and was treated at this time by another bare metal stent inside the bare metal stent. And there was a PLA lesion that was also tight and was treated with a Liberté stent, bare metal stent in the origin of the PLA. Then the patient came to us with recurrent angina, and we will show to you the real time of today, the coronary angiography, and then we will start to receive your questions and to receive your comments. Could you show us, فاروق لو سمحت, الكورونري انجيوجرافي بتاع النهارده من الأول?
Do you see the angio? Not yet.
Okay, so this is the coronary angiography of today.
Not yet. We are not seeing.
So this is the lateral projection. There is a bare metal stent within the mid-RCA, and it's relatively patent, showing mild and instant stenosis at its mid part. Then a diffuse disease distally. Okay, next. This is the LAO, show the same thing, that a patent stent in the long stent in the mid RCA, then a tight lesion just before the bifurcation of the distal RCA of 85% stenosis, then diffuse and stent-free stenosis of the PLA. Epicranial, please. This is the epicranial view. It's actually a long, very long PLA, showing a diffuse and stent-free stenosis and a tight lesion just before the bifurcation. The PTA is moderate sized and it shows minimal disease. So what do you think how to proceed for this case?
So this is a recurrent in-stent restenosis, because he had already in-stent restenosis treated with bare metal stents. He's diabetic, and I think that we should take in consideration that this is a big right coronary artery. I mean, it is. We'll show you later on the IVUS, and you'll see that it is in proximal part. The artery is huge. It's 4.0, even more. So I think it is very good case to discuss, because diffuse and in-stent restenosis you can see in the distal part. The proximal part of PL. This is the third or fourth time coming for angioplasty. So what is the opinion of the panel? Mm. Mm. Mm-hmm. Okay.
Oh. Yeah. The left system, yes. The left system is normal. He has a normal LAD with a minimal disease on the left circumflex. He has a chronic total occlusion of a small-sized OM branch that receives an epicardial collaterals from the LAD. For the left system, the patient now is classified as a recurrent in-stent restenosis. Not the first time. It's a recurrent on a base of bare metal stent with a diffuse disease and a small vessel disease with an uncovered segment. So what do you think how we start? We'll show you what we did, but we want to interact with you, with the panelists. Uh-huh.
Yes.
Mm.
Mm. No, actually, please. Mm. Well, actually, I think angiography in this case is misleading. And I think that as in every in-stent restenosis, in my opinion, IVUS is mandatory, or any intravascular imaging is mandatory, because you can see the right size of the vessel. You might see also the cause of stent failure. And particularly in this case, with diffuse disease, with dominant, I would say, dominant right coronary artery, because it's very big, So I think it is very important vessel, and it's very important also to go in depth about what is the cause, or to search about the cause of in-stent restenosis, whether it is mechanical, depending on the mechanical factor or patient factors. I think this is essential before doing anything. So, yeah, yeah. So
Yeah.
what we did, we performed the IVUS. We can show you now.
So we did the baseline IVUS. You know that it's a tight lesion. The IVUS couldn't pass to the very distal PLA, but we started at a reference from the distal stent, and we'll show you the IVUS. This is a baseline before any angioplasty, and this IVUS. ممكن الIVUS صح؟ show الIVUS.
Yeah, yeah.
Okay,
You see
so-
the IVUS now, right? Yeah, this is in stent distally, the distal stent in PL. And you see that there is not that much under expansion of the stent, because the stent is well expanded. There is much proliferation inside. This is a segment, unstented segment, which is the distal right coronary artery, where is the progression on native vessel. And you see it is very big vessel. And there is some diffuse intimal hyperplasia or plaque, and then we are getting
the
inside
proximal
the mid-segment stent. Here you will see that the stent, relatively to the vessel, is underexpanded, but he has almost 2 stents here. In one segment, he has almost 2 stents.
Yes.
For me, I think it is the area, the mean stent area, I think is still not significant reduction. We'll measure that. I think we have the measurement. Yeah, how much is the area?
4.15 millimeter
Yeah,
square.
4.5.
So this is the area which
inside
is
the stent.
2 stents. The 2 stents
Yeah.
are here.
Yeah.
This is the 2 stents inside the proximal stent. I mean the one 38 and the inside which is 3318. This is the segment, and this is the MLA of this area is adequate. It's 4.15. However, it looks like the stent was undersized. I mean that the choice of the stent was not appropriate. And there is also new intimal hyperplasia in this part of the artery, but it's not significant with a good MLA. For the distal one, you can show the distal one again. The distal one, the distal stent shows a diffuse new intimal proliferation with a very small area of minimal luminal area of 2.6 millimeter square, and I think it may be much more less in the, yes, in different views. Then anyway, we have a baseline of IVUS imaging before we started pre-dilatation. So we decided to do pre-dilatation with an NC balloon 2.520. Then we started to do the angioplasty. We'll show you the results of angioplasty. Next. Yeah. Sure. 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 Unfortunately, Dr. Yasser, you know, Dr. Yasser, you know that It was in 2008, and he was a governmental patient that at this time drug-eluting stents were not reimbursed by the government, and also the drug-coating balloon was not there. So I think the operator, we were not the operators, but the operator prefers to do just simple PCI to the stenosis area. And it was, of course, proven that it was not a right decision. But anyway, we have to face the problem. Now we have a minimal luminal area of 2 millimeter square here in the distal. And we have a tight lesion just at the distal RCA in between the two stented segments. And we have a minimal in-stent-free stenosis of 30% with MLA of the proximal stent of 4. So how would you think, or how would you manage this situation? Could you stent the whole segments? Could you use another technology? Could you use a non-coated balloon, coated coated DCB? Or you can just do high pressure inflations, so a scoring balloon. So what do you think, Dr. Mendes, Dr. Lafont? ممكن بالونة تانية 23 أو 15. Sure.
Yeah.
أهلا دكتور سيد.
This is a very good question. Actually, what we have today in literature, in studies, something that we can summarize like this. Drug-eluting balloon is better than conventional balloon, but not better than drug-eluting stents. That means it's something in between. We do not have that much supportive data on using drug-eluting balloon in diffuse end-stent restenosis. And this is the other question here. I mean, the other challenge here, whether we have to put another stent in stent distally to cover the whole segment, also in crossover distal distal right coronary artery, where it was a progression of a native vessel disease. So I think, yeah, the drug-eluting balloon will not give you, of course, the optimal choice in this patient.
You know, but we have data from the RIPS study, RIPS 4 and 5, and this is the 3 years follow-up of those patients, and it shows a very good or equivalent, near equivalent late lumen loss with everolimus eluting stents. Recently in the 3 years.
Late lumen loss is, I think that is surrogate endpoints. I mean, angiographic surrogates is not a good endpoint. I think we should look more on clinical outcome, not on minimal luminal diameter or end-stent or restenosis. So I think what is not clear today, or clear today, that drug-eluting stent is not equivalent to a drug-eluting balloon is not equivalent to drug-eluting stent in diffuse end-stent restenosis.
So we are now due. Sure. No, sure. Sure.
Yeah.
The size of the stent.
I think if
Deflate.
we looked carefully
Deflate.
on the IVUS, PL, the diameter of PL, proximal PL, where is the stent,
Ashara.
in-stent restenosis, is more than 3.2.
صور.
That means the stent there was undersized in the origin, I mean the index procedure. So I think we should predilate with the 3O balloon here in this vessel before doing any other thing.
2 4 6.
And then decide whether
صور.
to go with the only drug-eluting balloon in PL and the short stent in distal right coronary artery, or to cover in crossover all the thing with the segment stent in stent and covering also the distal part of right coronary artery. So it is very challenging. I mean, I don't like to add more metal in stent in a patient who are coming back for in-stent restenosis.
And he's diabetic, you know that he's
And diabetic. So it is not easy to decide.
Nitro.
Mm. Mm-hmm.
فلاش. زي أول ماسورة. The lesion is undilatable, this direct lesion also.
I mean, even put a wire in PD. PDA, put a wire because it's compressed.
هاتي واير تاني كده.
Well, actually,
So now we did the predilation with the escalation with the 3O balloon, NC balloon, and it looks much more better in the stent. But unfortunately, the lesion before in the distal RCA looks like there is some
Undilatable.
calcium. It's not a dilatable lesion. It's not an easy dilatable lesion.
it's calcified also.
It's a
you see it,
calcified
yeah.
lesion. So we have here now a different size in the PLA, in the distal RCA, and we have to protect the PDA now. افتح.
Mm.
شيل الزوم. distal wire وروني. Sure, yes.
Yeah, we can. I think we can try with the bulking
a scoring
device.
balloon.
Actually, given that in the stent in the right coronary artery is covered by the endothelium or by intima, I think also even rotaplator can be done here safely. I mean, it's not will not be a problem. But anyway, I think we can try with balloon and then
First.
we can try to prepare the lesion with cutting balloon or similar.
Just.
We are trying to protect PDA because there is some compromise on the ostium after dilatation of with 3O balloon. So any other idea from the I mean, from the panel about different approach in this case? Any other suggestion, different approach in this case? I mean, how can be done differently? Okay.
Just
Mm.
just
Okay. Okay, we can try. We can try with. Do you have cutting balloon here?
no, we don't have cutting balloons
What you
here.
have? Any?
We don't. We use the NC
Rocket.
balloons. So would you like to use the cutting balloon? Would you like to use the cutting?
No, for the distal right coronary
Mhm.
artery is undilatable lesion.
We can use a larger balloon NC if you want.
Yeah, we
okay.
can. We can use, but also short one.
Short one.
Not,
415 okay.
huh? Yes.
415 415 NC
What is the size?
4
No, 4
15.
is too much. Wait. 3.5, 8. Do you have?
yeah 3.5
8.
3.5 10
They do not have cutting balloon. I think we should try with a larger one. That means 3.5, non-compliant,
flex on it.
short balloon, and see what if we can
Kabir.
get something more. But I'll.
We have a scoring balloon here. We
Oh,
will try.
scoring balloon. Scoring balloon. It's okay. Scoring balloons will be fine. Good. Yeah, me too. Me too. I believe more in rotational atherectomy here. We can try anyway.
افتح فاروق كده.
We don't have any other options. I mean,
نعم. Sorry. Sorry again.
yeah, non-compliant.
No, it's an uncompliant balloon. It's an uncompliant balloon. Because we don't have a scoring balloon here in the lab now, right now.
So the only debulking device here, I think, rotoplator, right?
Rotablator, yes.
Yeah. So they don't have balloons, debulking balloons.
It's a 60 French. It's a 60 French sheath, yeah.
Yeah. Mm.
So بدي.
Yeah, actually. No. Sure. Actually, if we will be doing rotoplator, is not in for instant restenosis. It is before
Test.
the carina at distal lift main. That means before the crux, because there is the undilatable lesion, calcified lesion.
No.
It's
Yeah.
not inside the stent.
Bravo.
So we can just
Bravo.
limit rota at that segment
Bravo.
without going inside
Bravo.
the stent.
6 7
This is 3.5.
Yes.
Yeah.
8
Yeah, seems dilated. Yeah. Go
Yes,
up.
sir.
Go
10.
more,
Go.
more. 14,
12.
14. Go 14. 14.
14
14. Yeah,
16.
fine. Okay.
18.
You see, it is quite dilated.
It's
Yeah.
dilated now.
Okay.
Deflate.
Go down. Deflate. Okay. Just take a check now.
Test.
Yeah. Good.
Perfect.
Okay. Yeah, with the oversized balloon, that means it's balloon escalation 3.5, 8. Short balloon will give you more force. We get good expansion, and now its pre-dilatation is very effective. Coming back.
شوية سيبيه. ثبتي ده. اوي خالص.
Yeah, it's okay. Fine.
ثبتي ده. Fine.
No, I think now the next should be to dilate inside the stent, the proximal stent in PL with 3O balloon.
اوكي. يلا.
That means to overexpand the stent
بالونال هاي بريشر
with 3O,
3.
and then we see if the result is good. We can go only with drug-eluting balloon
I
inside that
Yes.
that
this-
stent and
yeah.
putting another small stent outside. I mean, in the distal part of right coronary
High pressure
artery and
therapy.
finish up like this.
عندك 3.
Do you agree with this?
هاتي 3 15 دي هنا. هاتيها.
This is 3O.
320.
Yeah. We'll go for high pressure. Because stent, so you have to go at least 14, 16.
كلهمش بقى يلفوا على بعض.
So now going with 3.0 balloon for the proximal stent
ثبتي بقى.
of PL. Where was the in-stent restenosis?
There is no sound. No sound. اللي هو ما فيش صوت. So the wires are
Yeah.
mostly over.
Wire overlapping now.
Yes.
Just the proximal. No. Okay.
ماشي. Okay. So now we will test
No, that is
this on the branch. Test this another one. كمان ما تخليش الوايرات يلفوا على بعض. Test. Hello?
Yes? Yes. You hear me?
خلاص
Yes.
خلاص.
Okay.
Okay.
You hear me now?
طيب. 2 4. Yes.
No, actually,
Yeah.
we
Yeah.
went with 3O balloon.
صور.
Non-compliant
Mashallah.
balloon was used,
Mashallah.
and that was making friction for
Mashallah.
overlapping of wires. He came back with a wire,
16.
the balloon crossed, and then rewired the PDA.
Deflate.
Now this is an inflation inside the stent with 3.0 at high pressures. That means 16, 18 atmosphere. Go on.
اوكي. يلا لاين. 2 4. 6 8 12.
Well, okay.
Deflate.
Could be also 30 high pressure.
2 4. 6 8 10.
If it's necessary, we'll go more.
12 17. Deflate.
Now we'll take an angio and then maybe IVUS better and see what
Surah.
happened there. Okay, take angio. Okay. Okay. Yeah. Okay. You see now it's changed. Something is changed. That means that the vessel is seen much bigger, particularly PL, I think. So I think we should check with IVUS again and see what we have there. If it is
So
good
big, yeah.
result, I will apply only drug-eluting balloon inside the stent and just putting a small stent distal right coronary artery where was the lesion on the native right coronary artery.
CB. Spetiano. Sure, yes.
Yeah. Angio.
Okay.
Show,
Right.
show the angio again. Angio.
ممكن نيترو وجهزي الايفس.
Sorry? Can you show the where is the technician? Can you show the angio?
افتح، هناخد صورة تانية. فلاش. افتح افتح.
Angio.
خليك معايا. افتح
Last
افتح.
one.
افتح. فلاش. خد صورة كده على الزوم.
This is the angio after pre-dilatation.
This is the last angio. You will
Yeah, this
show
is
it.
the last angio after yeah.
Perfect. Okay. هات كده نعدل الواير ده.
Now see me, it seems much better, but I think the IVUS will give us more details and then we can decide more appropriately, I think.
اوكي ايفس على ال PLA. Loads ممكن. So we'll do a control IVUS now after the pre-dilation with a 3O20 balloon up to 20 atmosphere. افتح.
Yeah.
Sure,
Yeah.
yes. استنى عشان
Again, the
شيل الزوم.
wires.
شيل الزوم.
I think the wire from PA. Take out the wire. Okay.
Yes.
Yeah. So we should go more. Go ahead, please. More.
قربي شوية. خدي ده دلوقتي.
Yeah, there is some difficulty to cross with the IVUS, to cross the stent completely. Now you see that it is in the proximal part of that stent in PL, but it is not enough. I mean, we're still having some hyperplasia inside, and but the stent seems much more bigger, of course, yeah. Yeah, we went 3-0. 3.5.
اوكي. تيجي بالونه 3 ونص
Okay,
كده.
we'll
15.
try to.
ستوب. اوكي. هاتي 3 ونص.
You mean proximally? You mean the lesion on right coronary artery, on distal right coronary artery, right? Okay. Yeah.
بالراحه يا حبيبي. يا نو.
Sorry.
بديهم عن بعض بقى. حط ايدك كده. اه. 3 ونص يبقى.
Okay.
Okay, we will. There is a chunk of calcium at the distal part of the stent, of the distal stent. We will pre-dilate with a larger balloon now, focal. Then we will try to see the control angio after that and the control IVUS, and we will decide if we will finish with a drug coating balloon and the stent, or one stent, long one, to cover the whole thing, or just drug eluting balloon of the two segments.
I think in between the two stents distally there is still something.
We'll see. افتح. So of course calcium adds to the difficulty of the case, but we'll try to
Can you cross this more distally? More
be
distally?
just
Yeah.
distal to distant. Yeah, we cross distal.
Okay. Go for 3,
1, 2, 3.
3, 4 atmosphere. 3, 4.
Yalla. 1, 2, 3.
4,
4.
5.
5.
Okay.
Stop.
Okay.
Deflate.
No. No. Now it's inside the stent. Okay. You
Okay.
can go.
1, 2, 3.
So high pressure, they saying
4,
is at least 25.
6, 7. Deflate. We are outside the stent still.
I convinced him to go for 16, 18. We are trading now.
Yalla. 1, 2, 3. 4. 10.
16, 18. Go. 18. Yeah.
16. 17. صور. Deflate.
Okay.
2 4.
Go.
6. صور. 8.
This is the only way to
10,
expand the
12,
stent, a
14,
stent implanted
16,
almost 10
17.
years back. I mean, it's not all the time
Sour.
easy, yeah. To go for high pressure and
Deflate.
oversize the balloon. Okay.
Okay.
Very
Test
proximate.
كده.
Go.
Test. Sorry. Test.
Pick back. Okay. Yeah, go.
اوكي 10 12 14 16 18
16,
20.
18. Go to 18.
20 صور.
Okay. Good.
Deflate. يلا 20
It's okay. It's okay.
Deflate. يلا 20 Deflate.
So, 3.5.
3.5
Non-compliant.
Test.
It's okay. It is distally.
Yes.
In between the two stems. But this is this is very big.
1 2 3 4 stop down Deflate. Iris.
Okay, let's take picture now and see.
Nitro. Nitro. زود الداي. زود الداي شوية.
Giving some nitro?
Yeah.
Yeah.
We have just 20 minutes, I think, so we have to finish.
Okay.
Open. Open. Flush. Okay. صور لحد آخر الفصل. Okay. It's much better now, I think.
Well, now I think proximal stent on
IVUS?
PL is very well expanded. We will go to check with IVUS again. But you see that there is also some distally, also at the mid portion of PL, some disease as well. But I think we should not touch that at all. Yeah.
Okay, we'll show you the IVUS right now.
Mm.
It's stuck in the same area.
Yeah, we are inside it
Yes.
a bit. Yeah, there is some friction there, but this often happen with the stent. I mean, yeah. And I think it is enough to start with from this. Can you start there? Yeah, this is now the stent, the proximal stent on PL, and you see that now it is almost 3.5. Yeah, it's very well expanded.
IVUS. IVUS.
You show them the IVUS, please.
Okay.
Wait. You see? Yeah. This is after 3.5 expansion of the proximal stent on PL, and I would say that it is excellent result.
افتح فوق.
Okay, coming back. Still within the stent. I'll keep it for you. This is distal. Okay. Back. This is a very proximal part of the stent. And this is right coronary artery now.
Yes.
Yeah. This is the site of the lesion. Yeah.
The site of the lesion.
Calcified, yeah, the calcified
The
lesion.
calcified. There is an arc of calcification here.
Yeah. And this is just very proximally to that segment, still diseased segment. Okay. This is,
The stent, the proximal
there is
stent.
some plaque there, but seems to still having good area, luminal area.
We are in the stent now.
And then this is the mid-segment stent. You can see here there are some overlapping of two stents in some segment of this. Okay. Okay. Some proliferation as well, and this is very proximal. And this is proximal right coronary artery.
Stop.
Okay.
Stop.
So, yeah. Yeah, there is a proliferation inside, yeah. Particularly in the segment with two stents, I mean overlapped stents. But I think now, accordingly to the IVUS, I think that we can go with the drug-eluting balloon because the result is quite good, and I think that now we have really very expanded stent, very good area in the stent with where was the in-stent restenosis, and I think that it could given a chance to drug-eluting balloon in this case.
Nitro.
Do you agree with this, or somebody will put a drug-eluting stent?
Flash. زوم صورة. حد داخل الفصل.
Well, the problem here is that if you are putting another stent in stent, you cannot get full expansion of
drug-eluting balloon 3.5.
yeah.
شو فيه كم؟
No. Yeah.
طويل.
You can see now on angio that we have some dissection inside also.
I think we have now a no limitation of the flow. We can put a drug coating balloon in the stent, in the distal one, then we cover the proximal undilatable calcific lesion with an sirolimus eluting stent. So we'll take now the 3.530 drug coating balloon in the distal. Okay, open it. Then we will see after the drug coating balloon what will happen.
I think also the matter here that the original stent is 2.5, and it is bare metal stent. It is not huge. It's not huge generation stent, and I think that you cannot go up more than what we have done. I mean, expand the stent more.
Yes.
So this is I think the maximum that we can obtain by balloons.
زي ما هي كده.
And putting another stent will not resolve this problem. That is the point, the key point for me. And I think that I will give a chance for drug-eluting balloon here without putting another stent. I'll cover only the small segment on distal right coronary artery, where on native coronary artery disease, without overlapping again stents. I mean. Seems to me the best option at this time. with the wire. Okay. This is very. Go. Go more.
سيني ومن غير صبغة كده.
Go more this.
We will see the سيني, yes.
You're still outside the carina. Go ahead.
Okay. We'll retrieve it slightly. افتح.
Yeah.
سيني.
Okay. Go.
Okay.
Go.
Hello. We will inflate now the drug DCB, the drug coating balloon. It is a sequent please neo. It's a polymer free paclitaxel. 1, 2, 3, 4, 5, 6. The nominal is 6. We will go up to 10. Saba.
Keep it 40 seconds.
10.
Keep it there. Yeah, it is
We'll
recommended
keep it for 1 minute maybe.
Yeah. 40 seconds is enough, I think. But anyway, long inflation.
You can see the ST elevation here on the ECG. There is an ST elevation because of prolonged inflation, of course. But we are about to finish the 40 seconds. Just another bonus of 5 seconds. 1, 2, 3, 4, 5. Deflate. Okay.
Still having a few minutes. Okay, so we can show now the angio.
Sure.
And then put the stent distally and that.
So we'll show the angio now, nitro. Okay,
Yeah.
we just will put the final stent and we will finish within 3 or 4 minutes. Flush. Perfect.
Yeah,
Okay.
Yeah.
Surah.
Yeah, seems good.
Perfect. You will take the stent.
Yeah,
for
I
the
think
distance.
now we will finish. I think we do not have time to stay online, but I
We
think
can
we will
stent.
finish with a small stent at distal right coronary artery 4.0 and finish up with this.
4 15 دعامة Coroflex. There's a minimal dissection of the PDA, but it's not a flow limiting.
No.
It's okay.
This TIMI3, it is excellent.
The ECG changes resolve, everything is okay. 4 كام؟ مفيش 4 3 ونص. Okay.
Yeah, deploying the stent in distal right coronary artery.
3 ونص 15. دي كام؟
Drug-eluting stents, of course.
ماشي يلا. Okay.
Is drug-eluting.
Hmm?
Is drug-eluting.
Yes.
Which
16. Hello?
Actually, in these cases, you will never have a big satisfaction anyway from angiographic point of view. You're still having something wrong, something is not dilated,
Hello?
something diffuse disease is like this. Statics should be left, and we should look on what is important for the patient, what is useful for the patient. I think at this point that giving a chance for drug-eluting balloon better than putting another stent inside.
Sure, I agree with that.
And in the future, if you need, we still having another option anyway.
Sure. Thank you. We will finish within a few minutes. We will just put this stent if you. Thank you. If you want to see this stent now, test.
Thank you.
Thank you. Thank you.
Thank you. Thank you very much. Thank you. Go
Nina,
ahead.
wrong.
I think go ahead. Go ahead.
Honey?
Go small. Until PD.